مساء الخير جميعا. مع حضراتكم احمد الضماطي. يسعدني ويشرفني ان احنا يبقى معانا النهارده دكتور احمد عثمان. دكتور احمد عثمان احد الطيور المهاجره المصريه الاصيله. He is حاليا the director of EP Lab at Florida Heart Rhythm Specialists. دكتور احمد ما هوش غريب على القصر العيني، هو خريج القصر العيني، وعلى مدى ال10 سنين اللي فاتت كان ليه ايادي بيضاء كثيره على المرضى المصريين الغير مقتدرين عن طريق دونيشنز بتقدم في هيئه ديفايسز كان بيركبها في الديفرنت انستتيوشنز اكروس ايجيبت. فبنشكر دكتور احمد على ده، وهو شرف لينا ان هو يبقى معانا النهارده. دكتور احمد هيكلمنا النهارده عن الابديت in cardiac and extracardiac pacing including resynchronization, physiologic leadless pacing and beyond. With that, without further ado, I'm going to give the mic to Dr. Ahmed.
Dr. Damati, thank you very much for the introduction. شرفني ويسعدني ان انا ابقى هنا في القصر العيني. ده يعني ده الواحد كبر هنا واتعلم هنا واتخرج من القصر العيني، فده بعتبره بيتي برضو. النهارده we're going to talk about different things in pacing. New horizons, new technologies, things that you will be seeing a lot more of in the future. حاجات we are not doing right now clinically and commonly that I think you will be seeing a lot more of in the near future. We're all familiar with cardiac resynchronization, CRT pacing. البار اللي فوق دي مخبيه CRT pacing for heart failure patients with low ejection fraction, wide QRS complex, and symptomatic heart failure. طبعا this, as you all know, involves inserting the coronary sinus lead, and as we will hopefully see with the next case, the next case is a CRT device that inshallah the lead will go to its destination very smoothly, and you will have excellent threshold, and you will have no diaphragmatic stimulation, and it will be a very stable position. That's hopefully the wishful thinking. The problem is that we have 30% of patients that sometimes don't get that result, and we have to then sometimes get very creative and try to maximize. It's okay.
أنا عايز بس أرجع السكرين شيرينج كده بقى.
We hope and try to achieve a good position on the lateral wall. We now have quadripolar leads that have facilitated electronic repositioning when we have problems with either threshold or capture or diaphragmatic stimulation, but we still have a few patients, perhaps some significant number of patients that we don't achieve that. As you all know, CRT therapy really works on all levels as far as heart failure is concerned, both reducing the endpoints of hospitalization and mortality, which are really the hard endpoints that we look at in all the clinical trials. All the clinical trials ultimately will need to look at recurrent heart failure hospitalization and mortality, and absolute mortality. We don't look at this. We can't very much tease out rhythmic or heart failure mortality. It's total mortality. But we also see that the left ventricle remodels with time and improves in function and ejection fraction. Left ventricular end systolic diameter does come down very nicely, and also the symptoms, which is really what most patients care about. Most patients really want to feel better. They don't want to live longer, and actually that is a true fact. You'd rather have good quality of life over longevity in many patients. The problem is that we have some difficult anatomies that we deal with. We have a significant non-response rate that we still have to deal with in many patients, which that's a whole topic of discussion separately. Some end up with complications, unfortunately, and with upgrades, you have an even higher rate of So one of the ways that we've looking at is delivering left ventricular pacing, cardiac synchronization pacing, leadlessly. And I wish I could move this bar really, and it's covering a little bit. But this is a new system. It's called the EVR system that uses a very, very small 9mm electrode that we insert into the left ventricle endocardially into a target position. So one of the problems with CRT pacing that we are currently all doing is that we're limited with the coronary sinus veins, right? We cannot really select the area of latest activation as we would ideally do, because we may not have a vein there. So we may have scar, we may have, so there's a lot of anatomical limitations. This, go back. There is this is an electrode that we can insert either retrogradely trans-aortic valve or transeptally through a deflectable sheath that will allow us to select a very good location for endocardial pacing of the left ventricle. Now, it's also endocardial, not epicardial, and we've all heard about potential problems with having an epicardial LV pacing with the dispersion of depolarization and refractoriness, which can be actually proarrhythmic in many cases. So this is true left ventricular endocardial pacing via a very, very small electrode that's about 9mm in length that we insert through the sheath, as I'll show you. How does this work? This works with a very it's almost like a subcutaneous ICD type of battery. This is the battery that gets inserted in the axillary area. It has a cable that connects to a transmitter, and the transmitter basically uses sound. So this is ultrasound that will activate this endocardial LV electrodes. Now, it is synchronized to all the RV pacing of any device. So any device that you have, you can use and add this endocardial LV lead pacing system to that existing device and synchronize by pace. So it's a very, very small little pellet, little electrode. And this is what the transmitter looks like. So you do a small incision in the precordial area between the ribs, typically third and fourth or fourth and fifth rib. And you test the exact location in the, and the distance to the lateral wall of the left ventricle to make sure that we're going to be transmitting effectively. Cannot be too far from it. And we suture this under, basically right in between the ribs, as you see on this panel here. And we close it off. So the pellet, the electrode itself is inserted through the sheath. We do look at it under fluoroscopy very carefully to make sure that we insert this tined needle, if you wish, that makes it anchored very securely to the LV endocardium. This is what it looks like in animal tests. And basically this will be a very, very stable electrode for pacing. So the SELECT LV study, which is the study that we were involved with, basically looked at success of implant, 97%. We've had a lot of patients achieve significant improvement in the endpoints of reduction in end systolic volume. The QRS width is immediate, of course, as you know, you would see, and actually particularly so in this case because we select the area of latest activation. So when you do that, you really are narrowing the QRS as much as you can in this specific patient. And basically there was significant improvement as well in New York Heart Association in those patients. So this is an option that we're really looking at. We are involved in the clinical study now. It's a randomized study looking at patients who have poor anatomy, who have failed a conventional implant, or who have had no response to therapy, CRT therapy, probably because of the lead position that they have. And also, we also are looking at patients who are too high risk for reoperation, high risk for infection, and offering this to them as an alternative. Okay, so the first was 13 patients with a study called the YCRT. We then moved on to the CE approval study, which was the Select LV study, and we're currently involved basically in the Solve CRT international study, which has been unfortunately slow to enroll during COVID. They completely stopped enrollment for about a year and a half or so. So we're back enrolling now. I have 3 patients in that study that are doing actually very well. So let's move on to another area. So we talked about the wide QRS, CRT, we're all familiar with it. But what about the patients who still have significant heart failure and have a narrow QRS? So only 30% of the 30 to 40% of patients with heart failure with reduced ejection fraction will have a wide QRS to go ahead and implant a CRT device. And as you know, the guidelines have been, you are probably more aware and familiar with the guidelines than I am, but the AHA, ACC guidelines and the European guidelines have always looked at 150 milliseconds. It's really a good number to keep in mind, because 150 and above, whether it's left bundle or right bundle, I think you have this synchrony, whether it's left bundle related. Even if you have a right bundle, there's significant synchrony of the left ventricle. So it's really a good number. When you get to the 120 to 140, which is what the US guidelines still allow us to do, you may not have the same benefit in those patients because of lack of mechanical dyssynchrony. So there are a lot of patients that do not have an indication for CRT who you optimize medications with, and they're still quite symptomatic. So what else can we offer patients like that? We have started to look at baroreceptor activation therapy, BAT. And this involves a device that, I'll show you a few things. So this is a device that basically has a lead that gets sutured into the baroreceptor area in the carotid sinus directly. So this is an ENT or a head and neck surgeon that will implant that stimulating electrode right on top of the carotid sinus, which is where you get the carotid, reflex basically. So what that does is that it does increase the sympathetic activity, parasympathetic activity, and inhibits the sympathetic activity, which results in lower heart rates, positive remodeling. There is some vasodilatation, so it's an afterload reducer, and that leads to a more effect as far as the heart failure intervention. So all of these new technologies had to go through an expedited process of approval and regulatory approval. As far as in 2015 or so, they decided that the United States was getting a little bit behind in having advanced technology available to patients. So they decided to really get more active and facile in having these studies, these devices be looked at. So a lot of these newer technologies that we're not used to have had a good chance to really be forwarded towards clinical practice and the practitioners and the patients. So small study, not 11 patients, showed that it's safe, that it works as far as looking at the sympathetic nerve activity and parasympathetic nerve, the autonomic nervous system. The phase 2 trial, Hope for Heart Failure, looked at a little bit bigger number of patients, and it showed that again, safety and efficacy in those patients. And then you end up with some endpoints of heart failure symptom improvement, hospitalization, and retrospectively, they looked at LV function, as I'll show you. So what did they see? We saw that you can, if you measure actual muscle sympathetic innervation for the sympathetic bursts per minute, you can see that there's significant reduction at month 1, month 2. And so on, persistent up to 6 months. So we don't have really long-term results, but I think there is there is evidence that it does work by reducing sympathetic activity. And we also could see that this is arbitrary. So what else did we see in those studies? This was retrospective, hope for heart failure, looking at endpoints of left ventricular function and heart failure hospitalization. There was a significant, small but significant improvement in left ventricular ejection fraction. So there may be a role for it. Stay tuned. I don't know how far it will go, but it's something that potentially could be added to anybody who has his ICD, who does not qualify for CRT, who have significant heart failure symptoms that we could hopefully help with on top of optimal medical therapy on all patients, of course. So fewer hospitalizations for heart failure, the length of stay has come down, and there was actually a reduction in significant cardiovascular events in those patients. Quality of life improved, exercise capacity, and New York Heart Association also improved in those patients. So there is a hint that it may be beneficial. We'll have to wait and see for longer term studies. Switching gears a little bit, do you remember the David trial? The David trial was a trial back in the early 2000s, I think, that really was an eye-opening study. So we had patients who got a defibrillator, just like the first case we did today, who basically got a dual chamber defibrillator. This study looked at patients being randomized to either a single chamber or a dual chamber defibrillator, just from the get-go. And they didn't have an indication for pacing. So they could very well just get a single chamber defibrillator for primary prevention or secondary prevention indications. And what was really surprising is that after a few months, you could see that there were more hospitalizations in the patients who got a dual chamber defibrillator. And that led to a whole expedition at looking at why is this happening. You know, we're supposedly giving them an atrial-based pacing device. And the problem was not in the atrial pacing component of things, but it was in the unnecessary ventricular pacing that in this specific population of heart failure patients, low EF patients, led to worsening heart failure. So we then really realized, and it's really emphasized and brought out to the light that we need to avoid ventricular pacing as much as possible. And if we have to pace, then we should be pacing in a more physiological way as much as possible, or avoid it altogether to begin with. So a lot of things that we've been doing, programming the devices to avoid V-pacing with the MVP algorithms. There's a lot of algorithms that you're familiar with. Perhaps putting it in other locations, which didn't pan out too much except for CRT pacing. But we also have started looking at his bundle pacing. So what's his bundle pacing? We are really recruiting the intrinsic conduction system by localizing his bundle and capturing it with with several leads. Now, this is a lead that Medtronic has specifically for that purpose, but all the companies now have their own leads that actually work very well with the sheaths that the company supplies. So Boston Scientific has a delivery sheath. Medtronic has one similarly. The largest experience has been with this Medtronic sheath because it's been there the longest, and that lead has actually performed very well for his bundle capture. So it's that has a little bit of a learning curve. It's something that is becoming standard in its second iteration, which I'll get to in a second. But what you can do is literally almost like you're doing an EP study with the lead. You can really see his electrogram at the tip of the lead when you're looking, when you're recording at unipolarly. You can see it very clearly and you localize it very clearly and basically end up achieving complete selective his bundle capture and pacing. And the QRS looks exactly the same as your intrinsic QRS. So this is an actual patient with a very, very long PR interval with intermittent heart block. And when you end up selectively capturing, it's really organic. This is the cleanest pacing you can ever achieve. It's really very rewarding for the patient long term, hopefully. And you can see that there's a little bit of a delay between the spike and the QRS, which is really his HV time. This is your HV time with the pacemaker in place. So now, and we have some studies that show that when you do this basically and compare to regular right ventricular pacing, you can see that there is a significant reduction in hospitalization for heart failure or death or upgrade to CRT device down the road because of low EF, because chronic RV pacing clearly can affect it. So his bundle pacing can really avoid this. What's the problem with his bundle pacing? The problem with his bundle pacing is stability. There is a higher risk of dislodgement. There is a little bit of a higher chance of high threshold in those patients, and we've actually seen also some delayed high threshold elevation in patients with the really selective or non-selective his bundle pacing. So it behooves us to be careful with it, but also if we have complete heart block, to have an additional lead as a backup in those patients. And that's why we've moved on to something else, which I'll show you after this slide. So one other thing that we've looked at is, which actually led to more left bundle pacing, is avoiding, is perhaps looking at this as cardiac resynchronization. So if you have a left bundle block and you have, this is the normal patient with the bundle, his bundle conduction, there is such a thing as longitudinal dissociation, which means that the fibers that are destined to go to the left bundle basically go parallel all the way down from the AV node down to the left side. And perhaps what we could do at some point in time is, if we pace a little bit beyond the level of block of the left bundle, then you can really recruit that left bundle and capture and then narrow that QRS to a normal QRS again. Now, how can we select the patients? You can only try and see what happens if you really look for that left bundle and see what happens. And we've had actually a couple of patients that really had very impressive outcomes just simply by left bundle pacing. So this has been looked at in a study. So this is an example, very wide left bundle patient, and literally just pacing a little bit distal to the level of block in the left bundle allows you to resynchronize the patient and achieve a very nice looking QRS. So there was a study, it was a small study, there was a lot of crossover, really 20 patients on each side. This was presented at the HRS 19, I believe, 2019. And it really did not show any statistical significance as far as improvement because of the numbers more than anything else. But it's worth looking at that at some point in many patients. So another area that I'm sure getting a lot of calls on is patients post-TAVR. And you have a TAVR program, sure? Very good. So this, what valve is this? Can you tell me? Which one? Medtronic or Boston? So, الصورة مش واضحة, I'm sorry. Okay, this is a self-expanding Medtronic TAVR valve, and basically those have a higher risk of heart block because the lower edge tends to sit a little bit on the lower side. فعلا مش شايفين كويس. Is it okay? So you can encroach very much on the left bundle with those devices, and we've seen a lot of patients that require pacemakers. So when do you discuss or look at the pacemaker? You have the indications again, the pacing guidelines. But if you have complete heart block, obviously you need a pacemaker. But I think we have to be very careful with any change in conduction. So any new conduction system disease after a TAVR needs to be really be carefully followed. Then a very high incidence of heart block down the road. especially if you've had a pre-existing right bundle. So if you have a pre-existing right bundle and you add any more insult to the conduction system, you're really in trouble. So if you have a right bundle, you have to be very careful with those patients. If you have a significant change, whether it's a significant prolongation in the PR interval, then you have to either monitor them very closely. And I know you don't have loop monitors, implantable loop recorders. Yeah, that's one thing that gives us a safety net, that we're going to be monitoring the patients remotely, but you should have a very low threshold to go ahead and implant a pacemaker if you have a significant change in the conduction system after TAVRs. And you end up with what we were just talking about, which is really looking at right below. So this is the lower cusp of the aortic valve, is really a good anatomical marker for your His bundle position. And you can see this lead here is exactly right there. That His lead is sitting right at the lower edge of that valve, and that's exactly where the His bundle is. So that's where you can capture very nicely and maintain physiological pacing. So because of the problems we've had with the left lead, with the His lead, I'm sorry, actually a lot of work has been directed towards achieving left bundle pacing, and a very large series of patients from China actually have looked at, now that we localized and we know very well where the His lead is, the His bundle is, we can perhaps go further down on the septum, a couple of centimeters down on the septum on the right ventricle, and be very perpendicular to the septum and really bore into the myocardium to hopefully achieve capture of the left bundle. Okay, and that's actually achievable in the majority of patients. You have to be very diligent at keeping at it and trying, spending a little time to make sure you can get that. And that gives you what kind of morphology will give you a right bundle branch morphology when you capture. And sure enough, you can end up with a very distinct left bundle capture, which we feel is very, very physiological as well. Now, the larger clinical studies are not there yet, but that will come soon, hopefully. I don't know why this is turned. Okay. Okay, so it's really becoming the standard pacemaker in my hospital now is a left bundle pacing lead, and the reason I'm doing that is because I think this is a very physiological way of pacing patients. They may not be having 100% pacing all the time, like chronic RV pacing requirement. But I think it's a very reasonable approach to have that should things change down the road, then they have more physiological pacing if they need to be paced more significantly. I think I'm going to have to skip on these slides, but I'll talk to you about another modality that's also very interesting, and that is cardiac contractile modulation. سمعت عنها؟ زمان. Exactly. Nothing has moved until they really started releasing it. It's now available, and it basically has to do. And I don't know why the slides came sideways here. I'm sorry, but it has to do. We'll have to turn your heads a little bit. It has to do with delivering with two septal leads on the right ventricle, high septal leads, delivering a high volt, long duration stimulus in a non-excitatory phase. So it's really not to capture, it just basically paces for 20 milliseconds at 7.5 volts at not to capture the ventricle, very close to the QRS, so that you're not capturing, you're not falling into a T wave and not causing any problems. But actually what that does is that it does stimulate increased availability of calcium intracellularly. So the acute studies show that it can increase contractility by increasing extracellular calcium entry and release from the sarcoplasmic reticulum. But also long term, it has shown significant improvement in function based on, you know, systolic volume reduction and diastolic volume reduction, increasing the ejection fraction. And I'm sorry again about these slides that messed up. Okay, and it's really become available now. So the indication for cardiac contractile modulation now is for patients who have an ejection fraction of 25 to 45%. So it's bridging a little bit the ICD indication and you know, the no ICD indication. And it's not, and it can be added to any existing system. So if you have a device already that's operational, you can add a separate device on the right side with those two leads. The direction is to see if it can be helpful for patients with heart failure with preserved ejection fraction. So we're looking at two ends. One is giving it to patients who have diastolic dysfunction and see if that improves outcomes in heart failure, but also looking at patients who are getting a defibrillator. So they have their own defibrillator now that has a single RV lead and these two dedicated RV leads that are purely for cardiac contractile modulation. So there's two studies that we are involved with in this, and we don't know how that will look like, but it may be an additional therapy for patients with a narrow QRS. So if you have a device and you have a narrow QRS and you still have heart failure, I think it may become available down the road. These are things that are not accessible everywhere yet. It's still very limited access, you know, even in the United States. But I think these are things that may be additional to what we do today. One other area in patients who have heart failure is the high incidence of central sleep apnea. So we're talking about non-cardiac pacing here. Central sleep apnea is truly a central phenomenon. It's a neural drive type of problem where the patient basically stops breathing during sleep. It's not obstruction, it's not snoring, it's just no effort whatsoever. The abdomen is completely flat, and that's how you diagnose it. It's a very common problem in heart failure. It basically, so it happens in up to 50% of patients with heart failure with low EF. It does affect also increase the incidence of atrial fibrillation. So there may be, you know, now we know that sleep apnea is a risk factor for atrial fibrillation, and it may be perhaps through central sleep apnea and hypoxemia. And not only that, we also know that all of these can affect the heart failure, you know, central sleep apnea, and the effects on the heart can really increase outcomes of hospitalization and higher rates of atrial fibrillation as well. So a lot of it is, so what can we do for it? So we can do actually, this is heart failure survival. Patients who have central sleep apnea, obstructive sleep apnea, and no sleep disorder breathing. So normal patients, it does affect their outcomes long term. So what can you do for it? I don't know if you can see this. This is another device that basically has two leads that go to a very, very small vein called the Pericardiophrenic vein on the left side. And that vein basically allows that lead to sit very close to the phrenic nerve on the left side. And it can basically capture the phrenic nerve, and you can, it turns on automatically at night when they're sleeping to allow that. And it basically stops when they wake up to go to, you know, to go have water or go to the bathroom. So when they change posture, it stops. But when they're laying flat and sleeping, it's activated. So it's a very automatic way of treating sleep apnea and avoiding the hypoxemia. So this is what it looks like on X-ray. It's a device that has a sensing lead and a stimulation lead, typically on the left side. The stimulation lead can be on the right side as well. I rely on the pulmonologists and the heart failure patient, the doctors, to refer patients who have a diagnosis of central sleep apnea for this type of intervention. As I was telling you, the therapy is really can be programmed. So if you go at night, you know, go to bed at 11 p.m. and the patient is reclining and is not moving, then it turns on. If the patient sits up or starts moving, it stops for a little time and then goes back on. So it's a very automatic way of treating central sleep apnea. So it's been validated in the pivotal study, and we are basically, it's currently available commercially. There may be, it's very effective in reducing the hypoxia and apnea. So you look at apnea-hypopnea index. That's what it's called. When you do sleep studies, you look at reduction in apnea-hypopnea index, and there's significant reduction in those. But it also has affected with the heart failure patients. It has shown some trend towards improvement in left ventricular function. It has shown improvement and reduction in hospitalization for heart failure. So there may be merit for patients who have severe central sleep apnea to look at in heart failure, to look at alternative therapies like this. We were talking a little bit earlier about leadless pacemakers, and we're all familiar with the problems that we face with leads. That's the Achilles heel of our pacing systems, all of them. And that's why you have to have a lot of respect. The first implant for the patient is a very holy time. Your leads, you have to respect them very much. You have to make sure that you do the best that you can to avoid potential long-term problems with your insertion of the lead, and make sure that you treat it very, very carefully, basically, because you end up seeing, like this X-ray, I don't know if you can see it here, but there's a fracture. And you can tell right away that this is a very proximal axis. This is a classic crush syndrome that you would have avoided if you reinserted the lead a little bit more peripherally, axillary vein or extrathoracic subclavian vein. This was really very, very medial insertion in this patient. So lead problems, fractures, venous thrombosis, hematomas, all of these kind of make us think or wish we have other alternatives such as leadless pacing. And clinically now, the common the patient is the patient that has had venous access problems. So dialysis patients, for instance, hemodialysis patients who've had recurrent infections, and you need to have backup pacing and secure pacing chronically. And elderly patients who have permanent atrial fibrillation, who are really not going to be pacing too much, sometimes you can look at having this very simple leadless pacemaker inserted. And this is what it looks like, the Micra, very, very small. As you know, it has the sensor programming and function. It's MRI compatible and a very good battery life. We now know also, and this is the sheath that I was telling you about. So this is the big sheath, the introducer, very large sheath, and you have a deflectable guide catheter, delivery catheter that allows you to be angled very septally and somewhat on the higher side, and see these tines basically deploy into the endocardium and anchor this pacemaker very securely. And we are achieving AV synchrony now with the newer system. It's the MicroAV. So in the majority of patients, you can sense the P waves. You can basically track them for V-pacing in patients with heart block. So it is very successful at doing that. This is not physiological pacing, but it's backup pacing. So, one of the things I always tell my junior colleagues is that we always have to be careful with pacing. Avoid this automatic long pause at night. Therefore, he needs a pacemaker. Holters will always have pauses at night in many patients. Sleep apnea by itself sometimes needs to be treated, whether it's obstructive or central, as we showed. It's one of the really good common causes of pauses at night, nocturnal pauses. I would really avoid the urge to implant a pacemaker because of a 6-second pause at night. That is absolutely asymptomatic. So we go back to the traditional conventional thought process where it's symptomatic bradycardia that needs to be treated, not the Holter monitor finding. There's no such a thing as a minimum heart rate when you're pacing. And we really want to be careful with when we have to pace to really either look at cardiac resynchronization or his bundle, left bundle pacing type modalities that will help us avoid heart failure down the road. So we're familiar with the subcutaneous defibrillator, which is a very, primary prevention, secondary prevention, even for VF. We don't really want to use those in patients who have known ventricular tachycardia because it's really a shock box. It's not going to be delivering anti-tachycardia pacing. We don't want this in any patient who has a pacing requirement. So if you have AV nodal disease, if you have sick sinus syndrome, this will not be helpful to the patient. But it really is an excellent line of therapy that I hope you have access to soon. Yeah. It's really a great, it avoids using the veins completely. You have no chance of any vascular complications. There's no lead fracture. I haven't seen a lead fracture with those. And this is an electrode that sits totally extrathoracically, extravascularly. So we were talking about leadless systems. Perhaps at some point in time, we'll have a subcutaneous defibrillator. You can have LV pacing via a EBR system. You can have a RV pacing via a Micra or a Micra-like device, and avoid veins completely in our patients in the future. I think we're hopefully heading that way, but we still have many ways to go. And I thank you very much. Any questions?
دكتور احمد بنشكر حضرتك شكرا جزيلا على ال very informative, very up-to-date presentation. And till the floor gets his questions, I have a couple of questions for you. So when it comes to implanting the LV lead endocardially, do you anticoagulate those patients for life, or is it for a short duration of time? So
acutely, while you do the procedure, you have an ACT of 250 and above. After the implant, you don't have to anticoagulate. It's a very, very small pellet, and the initial clinical studies showed that there was no need to anticoagulate. So it's not like a true lead that's implanted. So you are not required to have anticoagulation for those patients.
Yeah, I guess that's a very good option.
Absolutely. That's right.
So a couple of questions regarding his/left bundle pacing. Do you foresee that it will replace CRT for resynchronization or not? And the second question, in patients who are pacemaker dependent, you mentioned that you put backup RV lead. Is that the standard approach for all these patients, or do you think that in the near future, when the fixation mechanisms are reliable enough, are we going to just depend on these leads?
Very good. So the first question was whether we can avoid CRT pacing completely with left bundle pacing. I don't think so. And the reason is very simple. The only time you're going to achieve that is that you have a normal conduction system below the level of block. So if you have a left bundle and there's a level of block and below it, the conduction system is normal, then you can do that. You have to look for it. If you find it, that's a beautiful outcome. The problem is a lot of patients have conduction system disease distally. So you will end up with the scar patients, the ischemic cardiomyopathy patients. You will not replace CRT completely with this type of intervention because they have distal disease as well. So you still, CRT pacing is a very solid and established line of therapy for heart failure. It's been one of the most effective therapies that we've added in the last 20 years. And I think it's here to stay. This will be a very attractive alternative in some select patients that have a normal conduction system otherwise. So I try this in all the patients who are non-ischemic myopathy patients with the left bundle, because you will be surprised and you will see how amazing it can look if you really have intact conduction system below the level of block. So I don't think it will replace. The second question was the backup RV. So when I was doing pure his selective or non-selective, and selective and non-selective, actually non-selective means that there is a very small amount of myocardial capture outside the his bundle itself, and it really has to do with anatomy. The area, the zone of the his bundle can be impossible to capture selectively, meaning without any capture of myocardium. So you end up with either selective in 30% of the times or non-selective in actually the rest of the time. So it's not a slam dunk. you do that. But those are the ones that were unstable. So if I am doing an AV node ablation and I'm doing I need to implant a pacemaker, I always have that lead preferentially for pacing, but I have another backup lead for it. When I move to left bundle pacing, which is further down, that's a very stable thing. So left bundle pacing, as opposed to his bundle pacing, is actually a lot more stable. The lead performs beautifully, and it's very actually just by the fact that you have to, if you really want to achieve true left bundle pacing, you have to really dig in, push in a little more in the septum to really achieve that his left bundle capture. It makes it a very stable lead. So I am actually fine with just a single chamber pacemaker, left bundle lead, and an AV node ablation. The alternative is also you can do a CRT pacing. If you have a low EF, an EF less than 50%, and you're doing an AV node ablation, I think you should be pacing physiologically.
So my last question is about the nice trick of pacing the phrenic nerve through the vein for central sleep apnea. You would think that this pacing would cause kind of a jerky movement that is not comfortable, similar to what we see in CRT implantation when we get phrenic capture. Is it really the case, or is there a way to make it sort of more smooth going with the respiration?
So it's really obviously for patients who are not breathing at that with the central sleep apnea. Yeah. It's only at night, and it's not as fast as the heart rate. So you're pacing at a lower heart rate, which is the normal breathing rate. It's not a heart rate, it's a breathing rate. So it really affects just the breathing, and it's actually, they feel a lot better. They don't, it's sort of breathing. It's as opposed to not breathing.
It's not like a hiccup.
It's not the hiccup that you have with diaphragmatic stimulation with LV pacing. So they actually wake up feeling better. The sleep apnea is being treated as well. We're really recognizing sleep apnea a lot more in our patients. There's a lot of industry push for treatment, whether it's obstructive or central, but the central sleep apnea has become more recognized now, and we're really addressing it this is the one way. The mask, the CPAP, doesn't work for central sleep apnea. Actually, there's a Canadian study that looked at treating all sleep apnea, whether central or obstructive, and the central sleep apnea had worse outcomes. They had actually higher mortality.
Any questions from the floor? So we thank you again.
If it's new and it's a new left bundle, I tend to err on the side of safety. I think they deserve a pacemaker, because we've been really fooled a couple of times thinking, oh, we can monitor them, and the next time they come in, they have major injury. So the fact that it's a mechanical thing, this is not inflammation. Surgery is a little different. So surgery, you can wait a few days and see how it improves, because it's really more of an edema type of phenomenon, or irritation or inflammation. But with a mechanical valve that's pushing against it's not going to go anywhere. And if you see a change with that, I think I would want to have a pacemaker.
1 week. 1 week.
Yeah, if it improves it, then we'll die. So if the bundle improves after surgery, you're talking about just aortic valve replacement, right? Yeah. Yeah, I think it's actually a lot more stable with the surgery as opposed to the TAVRs. It's more dramatic with the TAVRs. It's really a judgment call. It's a clinical decision kind of for patients, but you clearly worry about a significant change that's persistent. So it's very good. So I don't know if you're familiar with it's actually the sensing of the mechanical mitral valve closure thing. So you see it's a pressure sensor as opposed to a true signal sensor. Yes. So it's an algorithm that's proprietary to the company that really analyzes the variation in the pressure that allows you to guess where the P wave is happening and track that. So It's not through contact or through electrogram sense.
Just gonna check quickly if there is any question on the Zoom. And I guess not, so we seem to be okay. Thank you very much again, Dr. Ahmed, and we enjoyed your presentation.
More than welcome. I'm sorry your audiovisuals were.
We'll get it fixed. Thank you very much. Thank you.
Sorry, I didn't prepare too much, and
It's fun to explore الحاجات
دي.